Good morning, good afternoon, good evening, and a very warm welcome to the 16th episode of our Let's Talk Primary Healthcare. Today, we focus on the role of primary healthcare in the well-being economy. And why this topic? The WHO European region had an event and started this discussion in early March this year. And they focused on the rich experiences that there are all over the world, and at the same time, the good evidence, but in addition to a very solid framework. And this conversation that started in March, we would like to continue with all of you today in this panel session and this talk show. For that, I would like to put two head questions to share with all of you. And one of them is how primary health care is building on a well-being economy. And secondly, how a well-being economy can promote the health for everybody. So those two questions are crucial, but the focus is primary health care. And primary health care plays a key role on that. Why? And primary health care conveys and works very closely with the communities, and with and for the communities. On the other hand, generates economy in where primary healthcare is based, for example, in terms of employment. And I would like to share with you that there is an economic cause for investment in primary healthcare. So having said that, and we would like to follow this discussion with the panelists today. But one of the things that's relevant is that this discussion will be open to all of you in the breakout sessions that we are going to launch just after this panel. For the ones who are new in these talk shows, there is a breakout session in Russian and another one in English. So please join us to keep and bring your thoughts and share your experiences, and you'll be able to share your comments with the panelists. So in the meantime, while we are running the panel session, one thing that we are asking to you is to show your name, so try to engage, and our colleagues will post some relevant links and relevant information related to and suggested by the panelists as well. So after this introduction, I would like to introduce the panelists in today. So welcome all. So I'm going to introduce with Janis Naik. Janis is an expert in well-being economy, and he is a technical officer at the WHO office in Venice, the office that works for investment for health and development. So welcome, Janis. We've got with us Maria van den Muizenberg. Maria is a family doctor, is a professor of health disparities and person-centered care at the Roundabout University Medical Center in the Netherlands, but at the same time, Maria has another hat. She's the chair of the European Forum for Primary Care. So welcome, Maria. And then we've got with us Jan de Maesener. Jan is also a family doctor, is a professor, and he is the head of the Collaborating Center for Family Medicine and Primary Healthcare at the University of Ghent in Belgium. And finally, we've got Catherine Rose. Catherine Rose is the Director of Impact and Learning of the Bromley by Bow Centre in London, in the United Kingdom. And with this, let us start our first round of discussion. I'd like to put the idea and asking a why. Why this topic is so prominent now in many countries. We know that there are different levels of engagement and actions taking place, and these will be some of the exercises that I'm going to ask to our panelists here today. And now I'm going to start with Janis. And Janis, the concept of the well-being economy is not new, we all know. But some people maybe would just like to know a little bit more. And I would like to ask you, as an expert, in those 3 minutes that I'm going to allow you, a very difficult task. And I would like to ask you, what do we understand when we talk about health in a well-being economy? Yanis, please. Unmute yourself. Thank you very much.
Thank you, Tony. I'm delighted to be here. Good afternoon, colleagues from across the region. Let me just start with what we mean by well-being. So when someone wakes up in the morning in a secure home with a decent livelihood, good social connections, they can participate in society, this contributes to their well-being. So well-being involves quality of life. It involves people contributing in society with a sense of meaning and purpose. Now, well-being indicators are getting more and more important to the health sector. They can tell us as an early indication whether people are failing to thrive, what risks there might be of ill health and of premature mortality. So for the first time, the European Regional Health Equity Status Report put well-being indicators on the agenda. We see 4 of these as key: mental health, limiting illness, self-perceived health, and life satisfaction. And what we see is that leading nations and governments are using these measures more and more to judge the success and the prosperity of their society. We know that people's health outcomes and well-being outcomes are greatly affected by social and economic circumstances in which they live. For example, the 20% of the population who have the lowest income experience twice the amount of limiting illness and twice as much poor self-reported health than the highest 20%. This exacerbates the risks of poverty and social exclusion further. So these concerns around low well-being are not just those of the health sector. They're shared by social affairs and labor ministries, central banks, and the United Nations. With these wider pressing concerns about climate change, social fractures, pressures on health and welfare systems, we see recent data that shows that there were 600,000 deaths in the European region during the first 2 years of the pandemic, from low investment in health systems and low investment in human development. This is despite economic growth for the past 2 decades, showing that our models are not producing well-being for all. So a well-being economy approach is about recalibrating the economy in a way that improves health, well-being, equity, inclusion, sustainability. This is what we mean by health as a beneficiary of well-being economies. So the well-being economy is one where public and private investment, spending, resources are used to improve human, societal, economic, and planetary well-being for all. The approach recognizes that we need to engage with a wide range of sectors as part of the solution. We need to create those conditions for people to lead healthy lives in dignity and to thrive, like social protection and decent work. We need to capitalize on the benefits across sectors, particularly from investing in 4 well-being capitals. Human well-being, I've already outlined what some of those domains might be. Social well-being, things like trust, cohesion, connectedness. Economic well-being, decent work, equitable societies, gender-responsive labor markets. And planetary well-being, things like good water and air quality, or stable climate. So I'll finish by talking about how health is also a driver of well-being economies. Health status clearly makes these vital contributions to people's livelihoods, their agency, their contribution in society. The distribution of physical and mental health is another key factor. Reducing inequities in life expectancy by 50% could lead to benefits of up to 4.3% of GDP. Universal health coverage, people having access to the full range of quality health services they need when and where they need them without financial hardship, is key in a well-being economy. And the health sector has a large employment and procurement footprint with wider benefits to communities, societies, and economies. In 2020, health and social work accounted for 10% of total employment across the European region. The health sector is one of the most stable sectors, ensuring continuity of livelihoods in places where the services exist. And primary care is particularly important in this respect because it's often a significant employer in rural areas. There are many other ways in which the health sector can maximize its contributions to the well-being economy, and I'm really looking forward to discussing those today. Thank you.
Thank you so much, Yanis. I think this is a very good start, and you've given some light on what the well-being economy concept entitles. And now I'm going to move to Jan. Jan, you have a remarkable professional trajectory. So you've been working from the theoretical side to the implementation and your practice at many levels. And we would like to, we know that you've been working on person-centered approach. You've been working very closely with primary health care, community-oriented, and at the same time, you are a believer on the psychological approach to the human beings. But I'm going to ask you a question. What are the key components that primary health care should introduce and impacts into the well-being economy? Jan?
First of all, thank you for the opportunity, and good morning or good afternoon to everybody. Of course, it is important to look how primary healthcare can contribute to what has been described by Yanis. And I use the reference frame of the quintuple aim to try to answer that question. You know that we had the triple aim, then the quadruple aim, and the quintuple aim. And let's look at the 5 dimensions of the quintuple aim and see how we contribute by making this happen to what Yanis has described. First of all, there is improving care as perceived by the person, by the individual. And I think that's a very important part of the work that we do in primary care to contribute to the well-being of individuals. And we use, as already said by Tony, this eco-bio-psychosocial model, which integrates the different dimensions, and we address those different dimensions in primary health care, focusing more and more and starting our work from the life goals of the person. What really matters to this person? That's a starting point of our interventions in primary care. And from these life goals, we look at the broader population and finally also at the planet. And that brings me to the second dimension where we contribute from the primary healthcare perspective, and that is improving the health status at population level. Already for more than 50 years, we use the community-oriented primary care approach, where we look at the local community, we look at the indicators, at the health status, and we look at the social determinants. And by doing that, we can address the social determinants and the upstream causes of ill health, contributing to well-being in that way, but also contributing to the conditions that make societies able to create more well-being, more quality of life for the individuals. The third dimension where we can contribute, of course, is that we try to create more value. And more value is not only this economical dimension. We talked with the expert panel on effective ways of investing in health about 4 dimensions when it comes to value. There is the allocative value, of course, fair distribution. There's the technical value, the best possible outcomes, evidence-based in the perspective of the person. There's the personal value, appropriate care to achieve this personal life goals of the individual. And not to forget, there is the societal value, the contribution of primary healthcare to social participation and connectedness. And I'm more and more convinced that this is where primary care can make the difference. The fourth, of course, is the well-being of the professionals. We are now completely concentrated and confirm that it is absolutely needed to focus more on well-being of professionals, and that also helps us to create well-being also for our patients, because we have to take care for ourselves in order to be able to take care appropriately also for the local populations, and doing that in a sustainable way. And finally, I think that with primary care, there is evidence that we contribute to social justice and inclusion, which is the 5th aim of the quintuple aim, that we especially do to looking at those most in need, but also to try to find out what are the upstream causes of ill health and what are the determinants that have to change in order to give equitable chances to everybody.
So thank you very much, Jan. And now I'm going to move to Maria, and taking the 4th point that you've mentioned here in a minute ago, and it's about the professionals. And Maria, I'm going to address to you now in your capacity of chair of the European Forum for Primary Care, a forum that brings together a number of disciplines that work together in primary health care. And I would like to ask, how do you see the role of these professionals in such the well-being economy? And what do you see as from this varied number of people trying to promote and to be engaged to aiming at the well-being economy? Maria, please.
No, thank you very much. It's very exciting to be here. I would add a bit on all the things that Jan already said, because I think they are much in the same line. And indeed, the European Forum for Primary Care represents over 100 members in 33 countries, covering the whole range of primary care professionals. So not only doctors and nurses, but also dentists, social workers, patient organizations, etc. And it's precisely this interprofessional collaboration that we need to achieve the quintuple aim mentioned by Jan. Better health and well-being among our populations can only be achieved in a collaboration. Primary healthcare professionals know their population and their living circumstances, and knowing the patient often over a long time, they have the trust, much needed as a pillar already mentioned, to discuss with their patients all aspects of mental, physical health, but also those social determinants of health. And to give an example, a dentist can see signs of malnutrition, but he cannot do anything about it. Then he can address the general practitioner and ask, do you know something of the family? What's going on there? The doctor will know something, and together they can ask the social worker, while we think this family has financial problems, please could you help them? So in that way, they working together can address these things. And a part of that, as we are aware of the huge health inequalities that are mainly caused over 90% by inequities in income and education, as these joint professionals together, we can support local and national, international policies that address these opportunities and create equal opportunities for good education and financial security. And as already also said, as a strong person-centered interprofessional primary care, we don't not only contribute to health, but also reduce costs by reducing, for instance, referrals to expensive disease-oriented specialist care. So I think in different ways, the strength is to work together to achieve those goals.
So thank you very much, Maria. And I think this lines very, very well with the next panelist, Catherine Rose. Catherine Rose, you are here. We are invited because you have different hats. And my first question to you is in your capacity of researcher. And can you tell some of the results of the evaluation you carry out in the Bromley by Bow, because this is links on what the previous speakers have said. So just giving a light of what you've been researching and the results of that, please.
Thank you. That's great. Wonderful question. And yes, I think my role here is to bring some of what we've been talking about into one case study example, which is the Bromley by Bow model, which is in East London. It's an integrated model of health and a community center, community anchor. So Maria's example there of the social worker and the GP, this is in a UK context, is very appropriate. And so I just begin quickly with a story of the work that I did there was ethnographic. So we were rooted within the center for 2 years, studying how does an integrated model work. So we understand already that, yes, it's making a contribution to, for example, the well-being economy, but how does it work in practice? That is what we're trying to understand. And how can it be measured and evaluated collectively? So these are 2 organizations, a community anchor with 40 different funding streams to support its activity in the east part of London, and a general practice, so a primary healthcare center funded through the NHS. So totally different organizations that are working by design together for 30 years to invest in the community and focus both on primary healthcare and delivery, but also social determinants of health and the kind of wider determinants of health. And when I came to Bromley by Bow, there was always 2 lines in the morning. One to come to the GP practice, a line out the door, and the other to go to the welfare advisor, a line out the door. And it was very important for us to tell the story collectively of what the contribution is of the welfare advisor and the general practitioner, but also the gardener, the artist, the nurse, the healthcare assistant, and these things collectively combine to support that local community. So for us, there are some very important principles that came out of that research, which other people can translate to their context. So I share those with you. So one, it was built for and by the community. So there are founders who were single moms, artists, local members of the community, 2 local GPs. So this was not an intervention from the state. This was built from local people. It meets the needs of the community and it creates opportunity. So the idea of health creation, not just addressing illness, is a very important principle to this model and something that I think underpins the idea of primary healthcare. Third, it has remained. So it's been 35 years and it has had many iterations, but it's invested in the community and it intends to stay. And this is something that primary healthcare, I think, also aspires to, but so do community organizations, community anchors. It has creativity and fun. So the idea of dreaming and innovation is a very important part of the model, which helps move from just addressing illness to creating health as well. Connection, many paths into meeting a GP, meeting a welfare advisor, meeting an artist, meeting English as a second language teacher. Many paths is one of the ways that the model works. And finally, it sits in this messy middle. It sits between very formal structures and targets and delivery of healthcare services, and also lots of creativity and ingenuity. And this is what the model offers. I think it's a beautiful example. So I hope that gives some grounding to offer.
Thank you so much, Catherine Rose. And I think this aligns very much with the next question and the next round we are entering now. So from your good practice, I want to keep building up the discussion on the good practices. And in this case, I'm going to address to Maria. Maria, you are a researcher, you are teaching, and you are in the practice dealing with disparities and vulnerable groups. And I'd like to hear if you can share with us some experience, maybe in the Netherlands or some other experiences that you've been working on. Maria, please.
Well, thank you very much. And it's very interesting, Catherine. Much of what you said will be echoed by what my experience is. So I would like to give 2 examples. One of an European project we were involved in to strengthen the well-being of refugee pregnant women, and another one of in my neighborhood, strengthening the health and well-being of parents with low income. And key in those 2 projects, and I think in everything we want to do, is the participatory approach with the people involved, so the refugees involved, but also all kinds of other people, professionals involved. So to give the example of the pregnant women, we, together with these women, we first discussed what would you need most to be supported, and they not only had questions about accessing healthcare, but mostly on where can I buy cheap clothes for my child? Where can I find healthy food? So we developed this peer support system, migrant women who knew our communities, working together and supporting these refugees. And then we worked together with midwives, social workers, the community center, the local government. And in this project, as well in the other project where we work together with lowly educated parents with very much financial problems, also there we work together with them. And for instance, for them, the most important issue addressing their chronic stress was that they would be more safety for the children. So we built more traffic safety. They got access for free swimming classes, which is very important in the Netherlands. And they got support by filling in all the difficult to understand documents. So you see that, and then in the end, we of course evaluated, etc. And then indeed their health and mental health especially was improved by interventions that were not strictly medical as such, but always addressing those social aspects of well-being, always doing it together with other people, with all people involved. So I think I leave it to that.
Thank you very much, Maria. And and now I see that you and Jan, you have many. You've been working in many parallel ways and quite similar goals. And I'm going to ask Jan. You've been trying to work on the transformation of primary healthcare, including the community as part of the primary healthcare concept. So maybe you could bring some examples that on initiative that you've been working on, and at the same time the impact you've had in your country as well. Jan, please.
Thank you. So in 1978, after graduating as doctors, we decided that we wanted to change the professional content of our functioning, and we started a community health center. We brought disciplines like nurses, social workers, family doctors, dentists together in order to try to give a collective answer interprofessionally to the challenges. And so we actually have a team with family physicians, nurses, assistant nurses, dietitians, health promoters, dentists, oral hygienists, social workers, psychologists, community health workers that are taking care of 6,100 people coming from 95 nationalities. So we have a very diverse practice where we try to give that answer. And we changed also the financing system from a fee-for-service system to an integrated, mixed and needs-adjusted capitation without co-payment for the patient. And that was a very important thing also. I will just give one example, I think, that speaks very much to the issue of well-being. I learned as a family doctor that for people, their oral health status is very important for their well-being, because that enables them to communicate. That shows who they are. And so we saw that there was a disastrous condition with mothers presenting already with their toddlers with problems of feeding, crying, not sleeping. And the oral condition of the toddlers was absolutely dramatic. And so we brought the mothers together, a group of mothers, and said, well, what's happening to these children? And of course, it was very clear. They said in a focus group, we cannot afford a dentist. We don't know how we can find a dentist. Our child is too afraid of the dentist. And to be honest, I am also afraid of the dentist. So, and then, I do some sweeteners in his bottle to stop him crying. But of course, that does not improve the situation. So there was a lot of important knowledge from the perspective of the mothers and the families. And then we started to do a survey. And we looked at children at the age of 13 months. And we saw that already 18.5% of those children had early childhood caries. But interesting was the social distribution. In high socioeconomic status families, it was 7.4%. In the low socioeconomic status, it was almost 30%. And there was a 100% need for treatment. So this correlation with deprivation, with nationality situation was the worst for children coming from Eastern European families, and none of them had already a dentist consultation. So what we did then, we brought all the stakeholders together, the local child and welfare clinic, the dental faculty, local organizations of citizens, policy responsible people that are involved in education, and also different socioeconomic actors and the schools, in order to see how can we address this issue. Can we try to find out what we can do? And from that on started a lot of collaborations with different kinds of actors. First of all, we lowered the threshold for financial access to the dental practice, and that was a very important thing. So we installed a kind of third-party payment that took 20 years. That changed before it happened, so that there was no more out of the pocket so much to pay by the patient. So that was a very important thing. But also we lowered the threshold by integrating a dental health center in the community health center. So we added a dental practice in this interprofessional primary health center, and that was very, very much a way to lower the threshold. And in the first year, we had 1,300 people showing up with disastrous oral situation. And then, of course, we also saw that the dentists were overloaded in their work and that they had not enough time to go for prevention. So we developed with a lot of other stakeholders a new profession in Belgium at the bachelor level, which is the oral hygienist, who is working in the community and in dental practices in order to address the challenges of oral health. And then we involved also our traditional program, which is health and family for the children. And we started a screening, which is now systematically at the age of 30 months for all children. So that are all ways to lower the threshold and to do early interventions. And we also tried to involve the preventive school health services. When we compared 20 years later, because the first survey we did in 2003, now 20 years later, we saw that today we had 11% of the children at the age of 30 months that have problems from early childhood carriers. It was 18% 20 years ago. You can say that's not a lot, but it's progress, and that's the way we go forward. And I think that's also the pace that we need to go forward. And we continue to work, and we hope to finally achieve the international average, which is 5% of the children at the age of 30 months. The at-risk groups are the same, so there's a lot of work to do when it comes to social determinants. Prevention and sensibilization is important. And of course, we try now increasingly also involve the students, because we have to train people to have this mindset to look at the whole context. And when we look at what well-being means for people when they have to interact with their family, but also in the neighborhoods, it's so important that we address the issues of oral health. It's so important for their personal and professional lives, and also for increasing their self-esteem. And it's just one example how you can, starting from an individual confrontation in a consultation with the toddlers and the mothers, come up with a kind of structural change so that more equitable care is put into practice.
So thank you so much, Jan, because this is an excellent example on your amazing vision that you had in that time. So we are talking about more than 20 years ago, and how this has impacted and scaled up, not just in your region, in your country, but even beyond the borders of your country. So congratulations for that initiative. And now I'm going to go back to Catherine Rose. Catherine Rose, now I'm going to address to you as an actor in this, but the actor on the other side, not as a researcher. I would like you to explain as a caregiver, because this is the other hat that you wear today. So as a caregiver, what can you tell us about your experience in this collaboration towards the well-being economy? Catherine?
Yeah, wonderful. Thank you. It's lovely to hear Maria and Jan talking about the way that we try to understand what's important to people who are living in community, maybe accessing supports, maybe accessing formal health services. So I suppose I will speak to my own experience, and then with permission, I will also extend back to Bromley by Bow and the research that we did there, because the stories mirror each other. I think one thing to say, and many people in the room here, the virtual room, will also be carers. So lots of us would do caring work of different kinds, whether that's for children or for older parents or for partners or friends. And I think we are starting now to widen our understanding of how to talk about caring and what that means. And what I would say, one thing is, for me, navigating the health system or the care system is quite a bit of what my caring work has been for the last 20 years. So advocating, trying to understand the system, what the person that I'm supporting is entitled to, what they're not entitled to, whether there are mistakes in the system, how to correct those errors. So quite a bit is actually administrative work, which I think sometimes is not discussed. And when we talk about an integrated system, one of the offers that an integrated system gives to a person and a carer is a way of navigating that system more easily. So in the Bromley by Bow example, everything is on the same site, not all services, but Jan's description of an oral health clinic on site. This makes things much easier to be able to go between these different kinds of services and supports. The GP, the primary healthcare center, can only offer so much. And then something like social prescribing, like they have at Bromley by Bow, helps you to link with other kinds of supports, some of which are also for the carer. And so I'll just share to say that we did ask that question also if we had community researchers within the Bromley by Bow project. It was very important to us that we mirror that principle of asking people locally. And the fundamental research question we had was, what are the ingredients of a good life? What does a good life mean to you? So not Are the services effective? Are the services appropriate for what you need? But this bigger question of what a good life means. And through that process, we defined community-based outcomes. So the services at Bromley by Bow now are measured in part based on community outcomes that were defined by people locally, which flips some of the service model, because then it means that the service is designed not just to meet the funding requirements or the expectations and the evidence base, which is all very appropriate, but also the local need and the local aspirations of that community. So we're very, very proud to be able to say that the model is now being evaluated based on practice knowledge, practice wisdom, as well as community knowledge. So I'm passionate about that on a personal level, but also, yes, professionally as a researcher.
So thank you so much for this concrete, and thank you for showing your even personal comments and here as a caregiver. And I like the link you made. And now I'm going to ask Yanis. Yanis, you've been able to be in contact with many international experiences at different levels. From the now we are hearing a lot about the local level, but maybe at the national level, you've been to Iceland, and could you share with us some of the initiatives and steps that countries are moving towards to a more focus on the well-being economy? Yanis, please.
Thanks, Tony. I'll just start with an example, if I may, and then I'll come to your question. So the cottage hospital model in southern Lapland in Sweden provides rural primary care in sparsely populated areas. And what this model is doing is really applying quite innovative and remote healthcare solutions like drone technology, digital solutions, and telemedicine. And it links this with the innovation cycle. So there's a link between the primary care provision and the development of innovation and the uptake of innovation. And this is one of the examples that shows some of the things we've been talking really about collaboration. And the range of approaches already on this call, we're talking about integration with social care, integration with arts and culture. So these models, they tend to start with this quite holistic view of health, or an innovative idea about how services can be delivered with people at the center and in collaboration. I think some of the key words that have been mentioned already. But we're seeing both these bottom-up approaches where you get innovation that's developed locally, but then also approaches that implement changes at scale across regions or nations. So whether it's the Caring Neighborhoods initiative in Flanders, where there's 133 projects linking often health with other services like planning, culture, employment, whether it's the village health committees in Kyrgyzstan, which select local residents' priorities and elect local representatives to their committees to define what matters to their health services. So there's a number of these initiatives. And what we're really seeing is that they're quite holistic in their approach. And another kind of key aspect that's already been mentioned today is the way in which these services are really grounded in the local places that they serve. So I think Catherine Rose used the word anchor. When you think of an anchor, you think of something really stable that really holds you to one place. And I'll give you one piece of evidence here. The public sector, actually, it's one of the most stable during economic recessions, particularly healthcare sector. And if you had a city of 3 million people and you spent 10% of your local spend on 10 local suppliers, this contributes to around 170 to 200 million locally to the local economy. So this is modeled for a city in the UK. So this is in pounds. But you can see how really some of these principles about collaboration, working with other sectors, and capitalizing on the value of the public sector really are driving some of these ideas in lots of different contexts, in very different ways suited to the context.
So thank you, Janis, for bringing this cross-sectoral collaboration. It's not just about health, it's how we can push the economy of some regions, some areas forward, just investing in these areas. So I like very much the examples that you've brought here. So we know very, very closely some of them, and we are working very closely with some of the examples you've given. And we must say that this is not just on paper, this is a reality that happens in those regions. So you see the economies and local economies in prosperity thanks to the starting point of the health sector and primary healthcare in many examples. So I'm going to go to the round 3, but I'm going to be very honest to all of you, the four panelists. I know that the topic is so exciting, we could go for hours and hours, but let's try to limit at the time, because otherwise we are not going to have enough time. And the second thing is that we are going to have time afterwards in the round tables, in the deep dives and the breakout rooms. So please, let's continue this discussion. So, and now I'm just going to ask you in a very bullet point way. So talking about barriers and opportunities about these actions. I'm going to start with Catherine Rose. Catherine, please, what are the main barriers and opportunities to actionable health in the well-being economy? So try to be very, very, very concise on that, please. Thank you.
Great. Yes, thank you. So first, I think the concept of the well-being economy helps us quite a bit. It offers us a broader way of understanding each other and how we are in relationship with one another. And this idea of, there's some principles. I've shared a link to the Wellbeing Economy Alliance about being people-powered, looking at the root causes of what drives inequality, thinking about fairness as a principle, thinking about community wealth as a principle. So these are all much bigger concepts than the current ways that we talk about economy, for example, just GDP and a way of understanding growth. So health as a social good is something that Janis was drawing our attention to right from the beginning. So just to give you a few opportunities, I think there are also barriers here, but I will frame them more as strengths. So first, leadership. Very important that we start to look at communities and individuals within communities as leaders within these systems. Bromley by Bow was founded by local people. It's a wonderful example. Many of us are living in community. We might be practitioners as well, but we are local people first. And so I think it's helpful for us to think about leadership and framing that differently as something that can involve local people. Also helpful to think about health creation, growth, expansion, not just treating of illness. This is the offer that we have, I think, when we think about the well-being economy. Third is to think about measurement differently. What we measure matters. It often drives our targets and indicators. There is actually very little robust evidence about the breadth of interventions and how they combine in an integrated model like Bromley by Bow. This is still very new evidence. And there's something very important about how we measure that. What are the methods that we use? We have to evolve our methods to capture that so that the indicators that we have and what we make decisions about is a better reflection of community values. And finally, I think it's very important. We talked about this idea of innovation. Janis brought that word in. Space to imagine what's possible. The systems that we're working in right now do not fully serve community need, and we have to start to dream actually beyond this current model. And so funding dedicated to innovation to support that's very important.
So thank you very much, Catherine. And maybe I don't know till what extent the audience know that there is one word that you mentioned, we've got 4 leaders here, and this is a good example. And bringing the 4 leaders in this vision is a privilege for all of us. So, and now taking advantage of the knowledge of Janis, I'm going to see, do you see any other important barriers or opportunities? Janis.
Thanks, Tony. So I trained as a doctor about 10 years ago, and when you're working in healthcare, it can be quite difficult to see what you can do to address some of these social, environmental, economic determinants. Are they outside of your remit? Are they within your scope of practice and the skills that you have? But we've heard some examples today, and I have two other brief ones to share that really show how primary care is driving action on these social, economic, and environmental determinants. So men's sheds are community-based initiatives, providing men the opportunity to take part in social activities. In Ireland, this type of program has shown increases in self-rated health, in life satisfaction, in sense of belonging, and other positive outcomes. The second is a model that was developed when some primary care doctors and professionals realized that many mental health conditions were driven by debt, insecure housing, other legal problems, with significant cost to other parts of the system as well, including the legal or criminal justice systems. So these were developed as partnerships, health justice partnerships between healthcare and legal services, giving support on issues like housing, like debt, and they improve the life circumstances of people accessing the service. They promote mental well-being. So you can really start to see how primary healthcare is tangibly addressing the economic, social, environmental determinants of health. There are many more, and we'll need to support people to do this at scale, sharing more best practice, training people to do these kind of innovations, supporting from the regulatory angle, the service design angle. So just a few things from me there. Thank you.
Thank you, Yanis. Thank you. I like that you've introduced even a clear example with mental health and justice here in this equation. And now I'm going to move to Jan again. Jan, you've been developing the vision of an organization, but at the same time, what you've done is a whole system transformation. So what are your reflections of what you heard or what you'd like to bring or add here, please?
First of all, if you want to transform a system, you need one thing, patient, and the second thing you want is also patience. Patience is essential if you want to change something. It takes time and health systems are complex. That being said, I would like to make a plea for integration of different works that actually take place in the WHO. We, some weeks ago, saw the excellent report by the WHO Council on the economics of health for all. The final report has been announced by Tedros, and that was a commission that and council that worked under the leadership of Professor Mazzucato. And the report says, well, economics has until now measured the price of everything and the value of nothing. That needs to change. Currently, health spending is treated as a cost rather than a long-term investment. GDP as the dominant measure informing economic policy does not help here. And I think that's a very important statement also when you look at the whole issue of the economy of well-being. And if you take into account the recommendations of this WHO Council on the economics of health for all, you see that many things show up that we have discussed today: human rights, planetary health, long-term finance, but also that there is this idea of collective intelligence, of common good, outcomes orientation. And I think that this report should be brought together with the discussion that we have today in order to come to a comprehensive and integrated strategy. Because the older I get, and I'm now 71 almost, the more I see that strategic integration is of utmost importance. We work very often in a very fragmented way. And if the economy of well-being wants to happen, and if primary healthcare can play its role in this, it will be through an integration of different analysis and different strategies that are built up nowadays. And the last recommendation of this report is, of course, important: build trust, because without trust, nothing will happen, and you will not have your population on board.
So thank you, excellent, Jan, to bring this report and to be able to share this so well summarized summary of the report. And now I'm going to give the floor to Maria, and this is a very open question. Any other considerations about what you've heard, about your own experience, and even thinking on the angle from the professionals working in the primary healthcare arena? Maria.
Thank you. All very important things have already been said, so I want to point out three other things. First of all, looking at barriers Of course, we are all aware of the lack of manpower, resulting even in medical deserts in our cities, but also in remote areas in primary care. And we need to address this by task shifting on one hand, but also by improving the working circumstances of our primary healthcare professionals. And one of the important things, not only money is there involved, but indeed, like the others have said, to show them again the beauty of our profession. And the beauty is to be there in a continuous way for your patients, working really together with the patient. So that's one thing. Another issue is that we really have to shift from the still existing paradigm of disease-centered, supply-driven healthcare system to a person-centered, integrated, goal-oriented, demand-driven system. And there I see a very important role of WHO policy. In fact, you have all pointed it out in numerous reports, but we could do more to also achieve this in financing of the system. And as a part of this, addressing the very still existing strong health inequities and relation between, for instance, income or education and health, we need more differentiated data. And I'm very excited that the WHO has recently started this data health repository on health inequalities. So I think we should enlarge this, involve also data on ethnic differences and gender differences, because they also exist, and to address not only the hard health outcomes, but also more general outcomes of well-being. So that's for the discussion now, 3 things.
So amazing. Thank you so much, Maria, because now you are bringing us to the future, and we are entering to the final round, to the 4th round on that. And I'm going to ask you a very generic question, and think that we've got about 6 minutes for the discussion. The question to all is: how do you see the future of the role of primary healthcare in the well-being economy? The future. So I think we are ready. So there are many opportunities. There are already examples here, but how do you see the future moving on? So to fulfill the 4 pillars or the capitals of the framework of the well-being economy. I'll start with Jan, please.
To be very short, first of all, I think that primary healthcare has to put a focus on continuity. Continuity, organizational, but also personal continuity. And for me, that's absolutely a challenge. There is no better investment than a social worker, a family doctor, a nurse that have been working for 30 years in the same community. That's the best investment a society can make. And I think we have to find ways to make that happen. Second, confronted with the multimorbidity increasingly and with the increasing problems of elderly people, we have to shift the paradigm from the disease-oriented model, as Maria already said, towards a model that starts from the achievement of the life goals of the person. And I think this goal-oriented care that starts from the question, not what is the matter with Mrs. Johnson, but what matters to Mrs. Johnson, is the absolute shift in paradigm that we have to make, because then our care will become relevant, will become also acceptable for the patient. And let's never forget that it is always a work that you do with a whole community. Our individual approach has to be embedded in a broader community-oriented approach. Let's not forget about that. And the final outcome of what we will do, and also the fundamental condition, is increasing social cohesion. When I have to sell today primary care, I don't talk about all the good things we do in the care of every day. I say to the politicians, what we need in your society is more social cohesion in order to make projects that are future-oriented happen. This social cohesion is a lot realized by good primary healthcare involving the local communities.
So thank you, Jan. So very, very good and very concrete objectives for the future. And now I'm going to move to Catherine Rose. So the same question, just being synthetic, if you can.
Yes, I think I'll just add one point, which for me is that all of the practitioners that I've worked with are incredibly passionate and dedicated. And I think what hinders them much of the time is the system and the constraints that they're working within. So for me, at a local level, when you look at how a GP practice is funded, the GP contract, for example, within the NHS, there is very rigid constraints there about what needs to be delivered, and not all of that supports the well-being of the staff. And I would say that's the same when we look at the well-being economy and how the state understands itself. The measures that we have around growth do not necessarily support the wellness of our population. So for me, the greatest opportunity we have is to start to redesign some of the commissioning and contracting arrangements, some of the constraints that are around practitioners, and to design that with them so that we can start to better design those services to meet both practice wisdom and community need.
So thank you. And I'm going to move the same question to Maria, please.
Thank you. I have little to add to the excellent things already said, but I would then focus to the more nearby future, because I think as primary healthcare, we can and have to be fierce advocates for equitable policies in all fields and support our citizens to fight for equal opportunities and rights, and above all, international solidarity and social cohesion, as Jan also said. And therefore, our European Forum for Primary Care dedicates its annual conference this year in Barcelona in September to this theme of international solidarity and social cohesion. I think there will be discussed in more detail all the good possibilities, opportunities we have to do this despite the quite severe times we're living in. Thank you.
So thank you, Maria, and this is an opportunity, I guess, is an invitation for all of you to explore the conference that's going to take part in Barcelona from the European Forum for Primary Care, and the topic is crucial and so aligned with what our discussion. So this discussion has many forms to keep continuing, and this is why I'm going to bring the floor and the last question to Janis. Janis, now with your heart of the WHO and as an expert on this field, how do you see the future and the future that you can share with us? Please, Janis.
Thank you, Tony, and thank you all colleagues. It's been a fantastic discussion and a privilege to be here. I have just 3 quick points to make. The first is we've talked about a wide range of models today, and there are many others. I agree that we need the evidence and the innovation, and also I think we need the systematization of these models. So we need to scale these up in a wide range of contexts in different places and make them work across the region. Secondly, the Alma-Ata Declaration 45 years ago recognized how social and economic development are vital for health, and also the importance of health for social and economic development. This year we celebrate the 45th anniversary in Astana, and we know so much more about those two relationships, and this conversation has been a fantastic illustration of that, and I hope that we can build on this dialogue going forward. Finally, I wanted to end on leadership. That's another thing we've talked about a lot today, and all the people on this call are the potential leaders of driving this agenda going forward. So I really hope and look forward to continuing this journey with you all in how we change services, deliver new models that take forward well-being, equity, and with people at their heart. So thank you to everyone for participating and listening.
So thank you, Janis, and I would like to highlight that this conversation should continue, and we've got many platforms, many spaces for continuing this conversation. One of them, as Maria said, there is a forum in Barcelona specifically on the topic related to that, and at the same time in October there's going to be the Primary Healthcare Conference organized by the WHO European region, and in one of the sessions we are going to tackle all these things. So the conversation continues, and we are going to invite you, and you'll receive invitations to register to the online platform that these discussions will continue from the WHO side. So I would like to, before we end, I would like to really say thank you to all of you panelists. It's been a wonderful discussion. I think the quality and the value that you've brought here opened many eyes, and I hope that some of these eyes opened will end up in transformations of at least a minor or meso or a big scale. So I think there is a great opportunity for that. I really appreciate your contributions. I think the discussion has been incredibly rich. And now what I'm going to address is to the audience, and the audience, now is your time, because we continue with the discussion. We don't finish here in the panel session. So we are going to invite all of you to join to the deep dive sessions. You'll see that in the chat, it will pop the link to get into the two breakout sessions. One is in Russian language and the other one is in English. And this will be an opportunity, if the panelists stay there, to keep asking questions, but at the same time, we want to hear from you. Another thing, when I would like to close saying that when you disconnect from the panel session, please, you'll receive a survey that it will pop up a window, and please respond to this survey, because this is important to us to provide a better talk shows for the future. And I would like, and with this, I would like to say thank you all. Thank you for being on the other side of the screen, and thank you for the panelists for this rich conversation that we've had. And I would say goodbye for now, and thank you for your attention, and we look forward to seeing you in next editions of the talk show or in the online platforms from the Primary Healthcare Conference in September and October. Thank you all.